right now.
Yeah, he's downloading something.
Okay. We're good to go. The floor is yours.
Well, welcome everyone. I am delighted to see you. I just came back from Cape Town, South Africa yesterday evening, and then I've been seeing patients all day. So I'm a bit running on fumes. I was actually doing quite well until I sat down about 15 minutes ago. And so I'm not quite on form, but I'm very excited to be here. I'm very excited to talk about this topic. So I will just jump into it. I don't know if I've had an intro. I'm a geriatrician. I've been in practice for over 20 years. I taught at UCSF, but I've had a house calls program for folks who were housebound, or they wouldn't go to doctors, or had behavioral challenges, medical challenges that hadn't been fixed. And so from that, I've distilled these ideas that I think are really important. And I look forward to talking about it, hearing your questions, and having more discussion after the presentation. So this is my TED Talk. However, I'm not usually doing it after I've been traveling or flying for 24 hours. Okay. As a hospice medical director, I've visited many elders needing relief of pain, aggression, and fear. As I entered one nursing home, I was struck. No one walked or talked. All heads were dropped, dozing in wheelchairs. At lunch, all plates had 3 mounds of glop: white glop, brown glop, green glop. Is this right? Should our elders be tranquilized? Does treating anxiety and agitation have to be this way? Bodies slumped in wheelchairs, baby food for lunch? Many criticize the use of psych meds in elders. Don't drug grandma is their battle cry. And yes, it's a disgrace to just sedate elders to make them easier to manage. Those skeptical of the use of medication for behavior often say that all problem behaviors stem from unmet needs. We know that music, caring for needs, spending really person-centered care, and spending time with elders goes a long way toward keeping them happy and healthy. Yet, is all well if we just stop medications? Critics primarily push to stop narcotics and antipsychotics, suggesting that any use of these medications in elders is always bad care. But the issue is so much more complex. Not all narcotics are bad. Not all over-the-counter or anti-anxiety pills are good. The geriatric principles are: treat pain, get rid of the wrong medications, always use person-centered care, and sometimes the right psych meds save lives and restore joy. Ellen awoke one night, sensing something wasn't right. She went downstairs to find her 84-year-old husband, Bruce, in the garage with the car running, trying to end his life. Soon after, he attempted to jump off the Golden Gate Bridge, but in a last flash of clarity, he called the police. They took him to the local emergency room. Ellen thought he'd get admitted to their psych unit, but without telling her, they sent him to a hospital 50 miles away, where he was treated with increasing doses of psych meds and then institutionalized closer to home. He didn't walk, he didn't talk. He looked vacant, she said, and he didn't interact. By then, Ellen was desperate. She looked for outside help and found a geriatrician, a medical specialist for elders. But she was skeptical. She'd seen so many doctors, tried so many changes. She challenged. She asked, is this right? Does it have to be this way? The new doctor followed her lead and challenged every medication and assumption. They started by tapering the anti-anxiety drug Ativan, really a sedative, with side effects of impulsiveness, paranoia, impaired memory, coordination, and judgment. It's strong stuff. They adjusted other medications, and he started to eat, walk, and went home. Several months later, he was more himself. That wry humor and quiet chuckle were back. Soon, he was serving Christmas Mass as a deacon again. As Bruce said, it's just wonderful to be here. 1 in 8, or over 30 million Americans, are treated with tranquilizers, as it's completely accepted by the medical orthodoxy. Actually, an aside, when I started this 5 years ago, it was 1 in 20, or over 16 million, so it's just skyrocketing. Elders are 1/3 more likely to get long-term prescriptions not recommended for them. Women and elders are 3 times more likely to be treated with tranquilizers for anxiety or insomnia, but tranquilizers are far from risk-free. Ativan, Xanax, Klonopin, even Ambien for anxiety or poor sleep increase falls and fractures, cause addiction, confusion, and aggression. All these risks are greater for older people. The most insidious part is, once started, tranquilizers are difficult to stop. Xanax is the crack of the suburbs. Its withdrawal syndrome is similar to serious alcohol withdrawal, with flaring psychosis, irritability, and poor sleep. Ativan can make elders look demented, act demented. As with Bruce, we can see that even doctors can misperceive the effects or side effects of withdrawal as being demented, as we saw with Bruce. It's not just tranquilizers. Numerous medications can cause confusion and aggression. Don't just accept all medications ordered. So the next time you go to the facility and see your grandfather, your mother, or your spouse slumped over a lunch plate or agitated and fidgety, challenge that. Ask about the meds. Investigate resources. Review the Beers list for medications that can cause problems for elders. Call the Alzheimer's Association. Many primary providers don't have extensive training in dementia. Seek out one of the 3,500 practicing geriatricians in America. The meds matter. Sue had lived alone for 20 years. She's thin with translucent skin, a shadow of the beautiful woman in the portraits on the wall. There's people that get into the house at night. They move things, she says, and make life difficult for her. Sue's isolated herself. Beyond help with groceries, she refuses all care. She screams if anyone comes in to organize or clean up the clutter in her house. I can take care of myself. But she can't. She's fallen several times, so her nephew, her only family, looked into placing her. Sadly, while he planned, she fell and broke her neck. In the emergency room, lashing out aggressively, she screamed in pain. She's old, frail, critically injured, and still psychotic. It took 2 people to keep her from charging off the bed. The doctors immediately treated her aggression with the antipsychotic Haldol and the anxiety medication Ativan. Yet, because of hypersensitivity to the opioid crisis, they didn't want to give her any morphine for her pain. It might sedate her. Sue's words were slurred and her chin and mouth were scrunched up in a hard neck brace. Her pain needed more effective treatment. The doctors feared that by giving narcotics with psych meds, she'd be too sedated. So instead, she was sedated with psych meds into a mix of silence and excruciating pain. Problem solved, right? She was discharged to hospice, and thankfully, they gave her narcotics for her pain. Her agitation subsided, her psych meds were tapered so she wasn't drowsy, and she spent her last months more comfortably with her pain treated. The meds matter. So, what if you're an elder without dementia? Is your pain better treated? Well, not necessarily. A study showed that elders without dementia reported severe pain before and after hip surgery about 50% of the time. This study, the researchers found that 75% of the time, people without dementia did not receive adequate pain relief. It was even worse for those with dementia. They received just 1/3 the amount of narcotics of those without dementia, which suggests that the majority of patients with dementia suffer severe, untreated post-operative pain. I'm not suggesting that all pain needs narcotics. Alternatives exist. Tylenol, physical therapy, topical and injection treatments. Some orthopedists use gabapentin to treat nerve and musculoskeletal pain. Some common painkillers cause problems for elders. Long-term use of Motrin or Naproxen increase heart attacks, strokes, hypertension, heart failure, kidney failure. A popular alternative, tramadol, increases confusion and sedation. So the next time your elder has tried everything for pain but is still suffering, a low dose of Norco may be just the needed treatment. Elders with dementia are a vulnerable population that cannot communicate their needs. They're not addicts manipulating their caregivers for more meds. They don't even know what medications they're on. We doctors have taken an oath to do no harm. Sedating elders in pain is harm. Bruce, a 60-year-old former physician's assistant, spent 2 months in the hospital. Why? Because no facilities would accept him. His speech and behavior were bizarre from frontal dementia. One person tried to bathe him, was seriously injured, and put out on disability. The hospital officials posted a security guard, not a nurse's aide, at his door. Essentially, Joe was on lockdown in a darkened room alone. His quality of life prospects were bleak. His wife looked for an alternative and found a geriatrician. They doubled the mood stabilizers and added a second antipsychotic before he stabilized. And yet, in this case, more psych meds were part of the life-saving solution. You see, it's not the meds that are bad, it's the misuse of medication that's bad. He was discharged to facility and once there watched closely in his room for a week. And then he joined the greater community unrestrained and without incidents for 4 years. Because his meds had been properly adjusted, his was not a tale of sorrow. He was free to enjoy a supportive community. And in the end, although he couldn't speak, he could smile and pat others on the shoulder, but he was never strapped to a bed in a room alone. His friends and family could visit, and they were tremendously grateful he was no longer restrained. He never had to return to the emergency room. As his disease progressed, the psych meds were tapered, and in the end, he was placed on hospice and died peacefully. One thing not commonly recognized about people with dementia, they commonly suffer severe delusions, paranoia, known as psychosis. Treat pain, get rid of the wrong meds, always use person-centered care, use antipsychotics for severe psychosis that does not respond to anything else and causes distress or risk to the elder or someone else. Well, this checklist is not commonly employed. It's exactly the recommendations of the American Psychiatric Association. In 2016, an expert panel reviewed all the studies looking at the treatment of agitation in dementia. Here's what they found. Treat pain. Let's see. Ativan and Xanax can cause confusion and aggression. Stopping them abruptly causes more confusion and aggression. They must be tapered slowly. The medical team should review the Beers list for medications that can cause problems in elders. This list is long and includes medications such as over-the-counter sleep aids, allergy pills like the Benadryl and Tylenol PM, Keppra, steroids, and anticholinergic medications that block nerve cell communication. The panel further recommended that if all other interventions had been employed and the elder was still delusional or aggressive, that antipsychotics should be used. Antipsychotics do require great care. There's a 2% increased stroke risk and a 1% increased sudden death risk. But for people with paranoia, they offer the opportunity for relief of distress and aggression and provide the possibility of treatment at home or avoiding the nursing home. This gifted care is one that's that's employed with less emotional distress to the family and financial savings to the family and society at large. The meds matter. Don't drug grandma. Let's see. Oh, I'm starting to lose it. Don't drug grandma. Look for. Let's see. Don't drug grandma. Oh, I'm going to just jump to the next voice. We always look to engage elders to treat their distress and aggression with fun, comfort, and music. When that doesn't work, some elders will need the right antidepressant, mood stabilizers, or antipsychotics to find relief. The focus must always be on the quality of life of the elder. The meds matter. Thank you. So I don't know if we can have a camera on the audience and have any questions. So for those of you who don't know me, I'm a geriatrician who has taken care of mainly the folks with medical or behavioral problems that have not gotten fixed with the regular doctors. And I just had someone who spent 5 months at UCSF because no one would take him. And he got discharged. He was very aggressive and he escaped and tried to choke another patient before he went, and we adjusted his meds, and now he's there. He's not sedated. We're not shoving him on hospice, but he's finally doing better. He's not walking so well. I mean, that is one of the side effects of the medications that definitely needs to be discussed, but there are things to do. So I am interested in any of your questions. I'm also, I don't know, I had it together until the end. And so if there are overall comments about how it's put together, except for that last paragraph, I'm definitely interested in hearing it. And oh, I put out a book, basically a guidebook for the treatment of dementia. You know, it's like what to expect when you're expecting. From when people, the other thing I've done is a lot of capacity evaluations and addressing financial elder abuse. So I put everything in the book, you know, from the earliest symptoms and the things that can make people look demented, like medications, and then a lot of vignettes of what can happen and how to address the difficult parts. I think the things that make it different is I talk about all the psych meds. I talk about the things that can affect diagnosing dementia, and then step by step, you know, what to think about as you're going along, from, you know, finding a care manager in a facility, or when to think about hospice. And then there's a big section about what to do financially. So yes, any questions?
Anybody have questions? Oh, yes.
Shauna, can you repeat the question?
Oh.
So I was wondering, it's probably pretty tough to ascertain if you're on your loved one or client is on the right set of meds. I'm guessing from your presentation that you should probably get a geriatrician involved sooner than later, or at what stage should you get a geriatrician involved, or from the beginning, or it's kind of a lot to unpack, but that's what I'm thinking.
Right. So one of the things I would suggest is, if you're, I remember going to a social worker support group, and they were saying, they're talking about some woman that was coming in to get chemotherapy, but she would unhook the chemo and then take the tube and then whip it around and, you know, squirt chemo on everyone. And they talked to her, they had her write out, you know, that she wouldn't do that anymore, and then she did it. If you're working with people like that, you know, they probably need a better, you know, cognitive assessment for what they're doing. When things are going wrong, when things are not working well, you know, this whole idea that you can have, you know, the mini mental status exam being something over 24 and then they don't have dementia and everything's okay, is completely, you know, bogus. And I talk about that in the book. That actually you can find that on the website. I have a blog post, you know, Trump gets perfect score on dementia tests. Too bad it's not the right test. And that's no knock on, you know, the former president. It's more that it's just a screening test that people treat as, you know, an ironclad, you know, certification that someone's okay. So I think when things are going off the rails is when you definitely want to get a geriatrician. And there's a variety of that. I mean, there aren't that many people that work with the behavioral stuff. So you have to look for folks who, you know, really address that. I think up at UCSF in their memory clinic, they do a good job with that.
So thank you.
Anybody have questions? I do. Oh, yes.
Speak really loudly.
Yeah, talk loud.
Or come closer.
All right, Dr. Liz, I've been listening to you for a number of years, and I know you have your list of do's and don'ts of what a dementia client should have. And I have kept those in mind when working with many of my clients. And I just recently had a dementia client in hospice. And her daughter-in-law was actually an oncology nurse. And during her final days, they put her on Ativan. And she had a horrible, didn't sleep all night, was agitated, and just an incredible change in mood. And I said, with your doctor, this is not recommended.
Well, so that's complicated. So I would not use Ativan, I would not use Xanax, I would not use Ambien for someone with dementia or someone older to treat insomnia. I mean, I just saw a lady today who's, been taking Ativan for the last 30, 40 years, but she also has a cup of tea every afternoon. So she has caffeine. So I'm like, no, she needs to have decaf in the afternoon. And then, we're going to taper down the Ativan. When it comes to active death, when someone was within a couple of days of death, I'm okay with Ativan, I'm okay with morphine. But what I think you're describing is terminal delirium, which is a little different. If she was up and she was confused and it was just, so let me just digress. I didn't really address delirium, which is something that can happen at any point, and it's more common to happen with people with dementia. It's a change in the mental status. It's acute onset with waxing and waning symptoms, and its most common symptom is inattention. So it sounds like she was delirious, and Ativan doesn't really do a great job for that. In that case, I would use Ativan for that delirium. I've seen a few people where they just get really confused, and right before death, you give them a little bit of Haldol, and they quiet, and they're clear, and they're calm. And there's no promise that anyone is going to get any particular medicine, and that's going to be the right cocktail, but it's more likely. So if someone is on hospice and they're declining, or they've been in the hospital for a while, but it doesn't look like they're going to die right away, I would not be using Ativan if they're agitated or if they're not sleeping. I would find other ways to treat it. I would look for pain. I'm a huge fan of using Tylenol 2 or 3 times a day, every day, for someone who's can't really communicate their symptoms, because if they have arthritis, that can make them uncomfortable, that can make them irritable. I also like something called gabapentin. That is anecdotal, and it works for about 85% of the folks. It helps with nerve pain, musculoskeletal pain, but for 15% of the folks, it makes them more agitated. So, everyone is different. In my book, I do talk a lot about all these psych meds, about when they can be used and, what problems they can produce.
Yeah, I was mentioning that with Ativan, actually, the end result, the behavioral change that was observed was the insomnia and the agitation.
So she got more agitated after she started the Ativan. Yeah.
It was removed immediately, and the daughter-in-law. Good point. We're not going to use this again. And
right, and you find that out for each person. I wouldn't say, oh, I never want to use Ativan for near death, because often it can be quite helpful. But you're right, for that person that didn't work at all. So good point. Thank you. Oh, can I ask? There have been people who have read the book. If you do get the book, if you read it, can you please leave a review on Amazon? Because I don't have a platform like Dr. Mark Hyman or Dr. Breedington. So
I can post a link to it for the Senior Roundtable Luma group, and people can see it there. I'll put the recording there as well. Are there any other questions?
Does anybody have? Yes.
So what's your thought about Lyrica and Methadone?
I like them. They're pain meds. So Lyrica is pregabalin, which is similar to gabapentin. It's not as sedating, and it can be more powerful to treat nerve pain. Again, 15% of folks can get more confused. Sometimes people get more sedated. but it can help. So if someone's got spinal pain, spinal stenosis, you know, there was one acquaintance of mine who was complaining that she couldn't sleep at night, but she had horrible pain, and she had some spinal process that they were giving her Dilaudid for. One thing to remember is narcotics can cause insomnia, and they don't help neuropathic pain except for methadone. So methadone, you know, for some of these little people who've got agitation, but they've also got a spinal problem, it can be, you know, a godsend because it helps with the nerve pain and musculoskeletal pain. But methadone is harder to use because, you know, there's a 1 in 100 chance that they'll have a life-threatening heart arrhythmia and die from it. And you also have that same arrhythmia risk. It's called QT prolongation with antidepressants, antipsychotics, some of the antibiotics like Levaquin and Cipro. So you've got to be careful. I mean, I've had 1 or 2 people who I've started one of those medications and they've dropped dead, you know, but that's out of like several thousand. But it's just, you don't, you want to make sure that the risks outweigh the benefits. But the Lyrica is definitely safer. Lyrica and gabapentin are some of the safer drugs out there. What I do want to point out, and I do want you guys to give me any feedback, is, you know, what I see people, I see doctors going, oh, we can't use narcotics for old people for anything. I've got a lot of people where, you know, if I use Tylenol and then I use some gabapentin or Lyrica and that doesn't help with their pain, I'll go to a half of a Norco twice a day. I have a lot of people on that. I've got almost no one on 2 Norco a day. So it's a very low dose. They don't escalate. They have no idea what they're on. If they get too drowsy, we just stop it. But those medications can help relieve pain and relieve the agitation. So I definitely think that it's, oh, I know what I was saying. So it's naproxen and Motrin that are dangerous. I've seen them cause heart failure. I've seen them cause strokes. I've seen them cause kidney failure. I've seen them cause GI bleeds. So those are not safer than a half of a Norco twice a day, as long as you treat for constipation. The worst thing I've seen from narcotics that I've seen several times is someone's given, you know, the Norco as needed after surgery. They take it, they get such bad constipation that they perforate their bowel. That, I think, is the biggest danger from the narcotics. So you got to make sure you give them bowel meds and make sure they move their bowels every 2 to 3 days.
Is anybody,
Any other questions?
any other questions? I wanted to say too, Dr. Liz, that I remember I worked in Menlo Park at a place, and you'd come in because I had a lady that was bipolar and also well, I don't know if it was Alzheimer's or dementia, but it was bipolar, and I don't know if you remember, she would chase her caregiver through the halls.
Oh yeah,
Yeah,
I remember her.
yeah, and she'd spit on the cops when they came for her because we had it 5150 or a couple times. And so now that as our elders are getting older and bipolar is coming out, are you seeing more people with bipolar and dementia? Are you seeing more of these kind of behaviors that you saw with the lady that we had? And
well, you know what's fascinating is that I was a hospice medical director up in Sonoma, and I saw a lot of people who were, you know, kind of, they had some pretty significant bipolar, but never got diagnosed. I think they probably just said that they were, you know, kind of nasty people all their lives, but they were really bipolar. So it's out there. And I think that we have a lot of trouble as a society identifying behaviors that socially sound okay. Like we all know people who are demented that they, you know, don't know where they are, they don't know what's going on, they don't know what they did 5 minutes ago. But the people who have dementia who socially sound okay, like my mom, you know, in her last year of life, she had frontal dementia. She had to be on, she was on methadone because she had nerve pain, and then she'd get Zyprexa because she could get pretty psychotic. And occasionally she'd go into a life-threatening heart arrhythmia and go into the ICU. Well, that happened 3 times in her last year. So we kind of came out and decided she needed to be in the hospice. And then she's like, I don't need this. Nah, I'm fine. I'm like, no, you're not, Mom. And so but this is in Colorado, and the hospice staff was like, well, she doesn't want to be in hospice. She's not going to be in hospice. I'm like, wait, whoa, and they're like, well, even though she couldn't remember day to day, but in the moment she sounded very reasonable. And so basically I took a big step back and I just said to my brother, fine, you take care of it. If you guys don't think she should be on hospice, you figure out what else to do. Well, within a month they had her back on hospice. I think there's a lot of people like that just their behavior is bizarre, but they don't really have the context to know exactly what it is. Or so bipolar, manic depressive. Manic is, they're up all night, they have lots of energy, they can be delusional, they can be grandiose, they can also have mood lability, they can get quickly angry, and that happens more with elders as they get older and those with dementia. Or they can be depressed, where they're just really kind of not engaged and just withdrawn and those sorts of things. And if the doctor doesn't know what they're looking at, they're not going to, kind of point out to the family what it is. Why should the family know what it is? So I think it would be good if our medical system would pay more attention to those sorts of things.
Yeah, definitely. So does anybody have any questions? I guess.
Why is this orientation dangerous?
Why is what?
Disorientation.
Disorientation?
What is disorientation?
No, why is it dangerous?
Why is it dangerous?
You mean delirium?
You mentioned before that dementia patients have a lot of symptoms, but you always want to watch out for
Disorientation.
correct. And why is that? I listened to your speech.
So she's asking why do we want to watch people and make sure that they're if they're disoriented, why would that be dangerous for them?
Well, two things. With delirium, where it's the acute onset, waxing and waning symptoms with inattention, that means the brain is really not working. And there's an association of death of 40 to about 60%. So that if they were okay and then they're delirious, that means that something's really going bad in the body. It could be a heart attack, it could be dehydration, it could be an infection. So you want to know what's going on with that. It could be a medication. If you are disoriented from dementia, you could have, poor safety awareness, or there's something, if your frontal lobes aren't working, but the day, the date, and the president, you lose your risk assessment. So you sound okay, and you've probably got control of your finances, but you can't judge who's going to, swindle you, or, there's the sweetheart swindle where the younger man or woman, sidles up to the older person, acts like they really love them, gets control of their money, and then just gets rid of the old people. I mean, there's different levels of disorientation and confusion. And I think that the most difficult ones are the ones where you superficially socially look okay, because then it doesn't get identified and you don't get help and you don't get protection.
Or you have Amazon calling you saying that or calling from Quebec, Canada, saying that you have a purchase for them to just press one.
Or you have the bank
Oh yeah.
not doing anything until they repossess your house because you haven't been paying your mortgage. Or you have UCSF, going after an older woman who came in with delirium and dementia, but she has no health insurance. And so when they did the MRI and the CAT scan, they ran a bill of $8,000, but then didn't get her connected with a doctor. So, I appreciate all of you guys. It takes a village to take care of these folks.
Does anybody?
Two more questions.
Oh, yeah. You have a question?
After hearing about the naproxen and morphine are not really good and cause bad side effects like bad for the heart and for the kidney, So we're lucky that we attended and we know that. But for those who didn't attend and who doesn't know it, how could it be prevented?
So you're asking about the naproxen and the Motrin?
Yeah, because she told it has a bad side effect, right? Heart attack and then kidney failure, but still.
Right.
But for us, the who attended, we know it. But for those who didn't attend and then giving it to the client, I mean to the dementia, what it will be for them.
Right. Well, there's my book, and there's the website, but then you can look it up online. It's a known side effect. I mean, I think there's just weird cultural quirks of our medical system, and I think doctors. There's only 3,500 practicing geriatricians in the country. So, a lot of doctors think that Ativan's a great thing to give to older folks to help them sleep. And I was called to see this one woman who, I was supposed to do a capacity evaluation, but then I found she was living at home, by herself. She could barely put on her shoes, but she'd trudge upstairs. And then her doctor was giving her 150 Norco a month, about pain to treat pain. And then she's like, oh yeah, I take this at night if I can't sleep. And she was living alone. So, and I mentioned to the doctor, I was like, she doesn't really have pain, and she walks up the stairs by herself, and there's like no side rail, and it's our societal problem that we don't really understand the changes that happen as we get older. It's something that adults probably should not be living on Motrin or naproxen either. It causes hypertension and vascular damage, but it's more extreme in elders. You can always contact us at drlizgeriatrics.com. We're working on an online training and education. We have CEUs now available for different training modules, and we're developing more, and we're doing telehealth. So I'm kind of pivoting into looking at different ways to get information out there. I'd actually love to hear from you guys, what your concerns are. Give me feedback on what we've got out there already. I have this bee in my bonnet that I want to make a difference beyond the few hundred families that I work with. And my team is changing. We were so sad to lose Robert from our team a couple of weeks ago, and another is going to be going back to college. So we're kind of really pivoting to what we're doing more telemedicine and telehealth.
Okay, thank you. Does anybody have any other questions? Oh, Wesley has a question.
Yeah, so falls are a big issue with seniors. So how do you assess that medication may be causing falls if you're seeing that your client is falling more?
Okay, so falls medication. There's falls medication, and then there's the lawyers. The lawyers can just blame anything. So I think some doctors don't want to touch any medication that could be implicated. What I do is if anyone's sedated during the day, I expect to be called. I expect that, you can't say, oh, they just have dementia, that's why they sleep. If they're on any medications that could be sedating, those medications need to be stopped. You need to have physical therapy, take a look at someone. When dementia progresses to the point where they have no safety awareness, like they'll lean over to try and pick up a little piece of lint on the floor, and possibly topple over, then those people are at higher risk for falls. If they start falling, then I move into, you don't leave them alone. You can leave them alone in a low bed that's only 9 inches off the floor. And then if they fall, they're not going to hurt themselves. You don't let them walk by themselves. You make sure you get them a walker. They are assisted when they walk, and then they're supervised when they're up, which is, more work, but that's how you get rid of falls. And, if they're in the wheelchair, you put them at the table and you lock the wheels, you sit them at the table. Some places will say, oh, that's a restraint. Not really. A restraint, I don't tie people into wheelchairs. I also like recliners, the power lift chair. because the elder, you can tip them and make it harder to get up, which I think is fair game. But the other thing is, anyone who's walking, keep them walking, because if you make them sit all day, they're going to get weaker. If an elder does not walk, if they stay in bed, they lose 5% of their muscle mass a day. If they sit all day, they're going to get contracted, and that's going to make it, harder to walk. If they are not walking and they are chair bound, then you have to reposition them. Then you have to have staff move them, and then you're going to have more injuries to your staff. So I think it's worth putting the money into someone to keep everyone moving up front, and then you're going to have, less cost downstream.
Well, thank you.
Oh, can I ask, was the talk helpful?
Yeah, definitely.
Good.
Thank you.
Were the stories relatable? Anyone want to say anything about that?
Oh, I think everybody's lived each of those stories, I'm sure. Somebody. Well, I have several of those stories.
Well, that was what I was trying. I mean, I gave this talk at one place, a leading age group. And so I gave the whole talk. And the first question was, what's the difference between a person with dementia and a demented person? And I changed, the studies. I was, and then someone else was saying, if someone says demented patient, I'm gonna lean across the table and go for them. And I'm like, I didn't take it well. I was saying, well, Mrs. Lincoln, beyond that, was there anything about the talk that I've learned? So yeah, I think I found that these concepts are really powerful. It makes my job a lot easier. And when people are really agitated, the ones that go into get admitted to the hospital, the average length of stay is 60 days, and the average cost is $600,000. I can get them out in 4 or 5 days by changing the meds, getting them to one of the communities who can handle them, and I don't sedate them, and I don't just push them on hospice to die, which I have seen. So I think it's hugely powerful. If you guys can give me any feedback about who to communicate this with, I'm a little baffled as to how to try and get these concepts out.
Okay. So
Thank you.
Cheryl.
Thank you, everyone.
Thank you.
Have a good afternoon. Bye-bye.
Bye.
Oh.
Andrew.
Well, I'm sure you're probably tired of sitting. Your knees are probably stiff and everything. You must be thirsty and hungry.
Does anybody want